All right, sorry for the delay. I was figuring out how this thing works. So I'm Dan with Jump Bag EMT, and I'm here to talk to you guys today about National Registry and how difficult this thing can be. So here's the thing, we're just going to get right into it. People study stressed. People are really concerned about the test, and so they sit down when they do their study and they do their practice exams, they're already studying stressed. They're sitting down in a stressful environment. They're sitting down without notes. They're thinking about way too many things. The best way to study, in my opinion, is to try to get relaxed, get into a comfortable situation, get into a comfortable position where you can just go through your material. I don't care which test suite you use, which practice exams you use. They're all fairly decent. Some are better than others, but the same concepts and the same contexts are in all of them. And if you can understand how to take the exam and you can apply the information you learned through school, you can do all right. So find a place where you can relax while you're studying, because that's going to translate into taking the exam relaxed and ready to roll. Concepts and norms. National Registry is testing concepts and norms. They don't expect you to know everything. They don't expect you to remember the book. What they do expect is some correlation. When you see the word barrel chest, do you think emphysema? When you see the word fever, do you think infection? They want to see if you can correlate these terms. Respiratory emergencies look like respiratory emergencies, but the individual respiratory emergencies have something unique about them so that you can register what it is, whether it be barrel chest or the green sputum and fever for pneumonia. These are the correlations they're trying to look at. We talked a minute ago about the testing suites. There's some that are good, there's some that are bad, and there's some that are awkward. But they're all going to get you practicing the exam and moving from point A to point B. You're not memorizing test questions. You're trying to apply information. So it's important to get those reps in and not just try to memorize the questions, but look for the correlations. Next, your notes. While you're sitting down and you're taking your practice exams, get a piece of paper out and start writing down your notes. It's not cheating while you're studying. If you're taking an exam and you come across a topic that you don't understand or you don't remember, write it down. On test day for National Registry, you're going to have that whiteboard, you're going to have a note sheet, you're going to have something that allows you to write things down. So why not practice your exam the same way? When you come across a difficult topic and you're not sure, write it down on your notes. Later on, after your practice exam, you can go back and look at your notes and say, hey, I really struggled with this area, or I don't remember this word. Then you can go back and you can look it up and maybe make a little shorthand note on that sheet. If it's really something difficult to remember, you can practice writing that down on your sheet, and then come exam day, you can write that down in the beginning on that whiteboard, that piece of paper that registry gives you. So have that piece of paper and have that note ready and available, that notepad ready and available, because it's just going to help you study later. It's going to be a detailed study guide. Next is your assessments. A lot of folks have a problem with the assessments. They don't memorize them. 1/3 of every chapter is assessments. You've got, for JB Learning, for example, you have, okay, these are cardiac emergencies. These are the criteria. This is what it looks like. These are the different names. And then you have the assessment of your cardiac emergencies. And then you have your treatments at the end third of the chapter. Every chapter is like that. 1/3 of every chapter is the assessments. That tells you a lot. 1/3 of the entire book is basically your assessments. And how many patients are you going to do assessments on the rest of your career? Every single one of them. So know your assessments. When you're looking at your medical and your trauma assessment, those old sheets that were given out by National Registry, those skill sheets, they gave you the order of importance for them. As you talk to different instructors, different people, they'll say, well, that's not how we do things. That's not how it actually happens in the field. And they're wrong and they're right. They're wrong in that we actually do all those steps. We're just stepping off an ambulance with 2 people or stepping off a fire engine with 4 people so we can multitask. Because we can multitask, we're knocking out a bunch of those things at a time. But come National Registry, we're one person doing one thing at a time working down an outline. So you have to have that skill sheet memorized because National Registry is telling you what their priorities are. Granted, on a real call, we're going to get vital signs right away. Well, you've got multiple people, so they're getting vital signs while you're doing your primary assessment. So when you're taking the exam, find out what's reasonable and then what's in order. What comes first based off of National Registry's priorities, which is that skill sheet. That is a big step for people. So I like to break it down kind of simply into, hey, big five, right? So we got BS. This is how I start my skill sheet. My first 6 steps I call the big five. So first I bring up my hands, BSI. Okay, this is step 1. And then my 5, right? Scene safe, mechanism of injury versus nature of illness, number of patients, consider additional resources, and consider C-spine. If you got those 5, you're already rock and rolling through your medical assessment. Next, you're going to come into your general impression and level of consciousness. One of the things that we get mixed up is that we start our assessment right here on the patient, right, when we're doing our training, and that's not how it works in real life. That's not how we actually do it. If I'm right there on my scenario for school, I already want to touch your face. I already want to start the assessment, but we're not there yet. So for example, if I was running an assessment, this helps you memorize it, I might practice coming in through the door. So coming in through the door, right? I'm going to start with my big 5, BSI, scene safe, mechanism of injury, nature of illness, number of patients. All right, there's my big 5. And now I'm coming in my general impression, like I'm hunting or like I'm walking in the room carrying my bags. So there I go with my general impression. On my way over there, on my way to the patient, I am looking at general impression, level of consciousness. Are they awake? Are they asleep? What's going on with them? What is the context of what I'm dealing with? So general impression, level of consciousness. Next, chief complaint. What am I here for? So, hey, I'm Dan with the fire department. What's going on? What brought me here today? So I'm getting the chief complaint, but I'm not even to the patient yet. So chief complaint and apparent life threat. This is one of the steps that people miss that's really important. Apparent life threat, this is what's going to kill them. What is going to possibly hurt them and take them in the wrong direction right now? Do they have a pulse sticking out of their stomach? Are they pale, cool, and diaphoretic? Are they obviously not perfusing? Are they bleeding, a massive bleed? Are they not breathing? Are they face down in their vomit? These are apparent life threats, and I don't move any further down my assessment until I square those things away. So this goes along with my general impression and apparent life threats. How does that patient look, and how are they doing? So general impression, apparent life threats. Next, we're coming into actually looking at that patient with the ABCs. And I call this my ABC PPT. So airway, breathing, circulation, priority patient, and transport decision. ABCs, do they have an airway? Well, I kind of ascertained that on my walk in, right? Because when I saw what their level of consciousness was, they talked to me, I know if they've got an airway or not. Now, breathing, if the normal respiratory rate is 12 to 20 breaths per minute, and one normal breath is 3 to 5 seconds, we know as I walk up to that person, if they breathe twice in 5 seconds, that's a little weird. That's a little fast. If they only breathe once or hardly once within 5 seconds, that's weird. That's their breathing is not doing well. I'm going to have to intervene and do something right at this point. The other thing I like to do is I come in and I'll feel that radial pulse and I'll put my hand on the patient's neck like this. While I'm doing this, I'm actually watching that chest rise and fall to see if it's weird or not, whether it's fast or slow. And I'm also seeing if they've got a radial pulse. If they've got a radial pulse, I'm kind of figuring that blood pressure is above 90. And so they're not overly shocky, right? Or they're not unstable yet. Maybe they're on the decline, but they're not unstable yet. They've got a radial pulse. So I'm thinking their blood pressure, their systolic is at least above 90. And I'm getting the temperature. And so with my breathing, with my circulation, I'm looking for rate, rhythm, and quality. So we talked about the breaths, but going back to the radial pulse. If the normal pulse rate is 60 to 100, 60 seconds in a minute, if I'm feeling their pulse and it's regular and I feel it about once per second, I know it's regular. I know it's normal. If I feel it almost twice per second, I'm thinking that's pretty normal. But if I don't feel it within 1 second, it's weird. It's slow. If I feel more than 2 in a second, it's weird. It's too fast. I'm not even getting vital signs yet. I'm just getting that primary assessment, figuring out if this person is stable or not, and whether I need to do something. So ABC and then PPT. Next, for the PPT, I say priority patient and transport decision, because this is when I'm deciding, am I going to load and go? Am I going to stay and play? What do I want to do and how do I want to handle this? And so this is where I'm deciding where they might need to go. Are they testing on the stroke assessment? So I need to take them to a stroke center. It's not just whether or not I need to go, it's where do I need to go, right? Do they need to go to a cardiac center? Do they need to go to a trauma center? Do they need to go to a pediatric center? What am I going to do and what is really helping us out with this assessment? And then patient priority and transport decision. Where am I going? How am I going to get there? Now, when we're doing medical assessment or trauma assessment, same. If you look at your skill sheet, that first half is identical. It's identical. The BSI seen safe, mechanism, injury, nature of illness, our big five, all the way down to priority patient and transport decision is the same. It's the second half of the assessment that differs. A lot of the National Registry exam is going to focus on this beginning section. And as you'll notice in this beginning section, the vital signs were nowhere to be found. That's all the way down in your secondary assessment. So don't get ahead of yourself. Okay. So knowing the assessments. Now, for actually practicing the test, let's see if I can actually share my screen on here. Like I said, I'm kind of new at this, and bring up a practice exam. So let's see, screen share. I don't think it's allowing me to do it. All right, well, let's talk about some practice exams. I'm going to pull one up on here, and you can't see it, but I'm going to talk you through it. All right, so question number one. Actually, I'm not even going to read the question yet. What I like to do is I like to look at the answers, because sometimes just looking at the answers is going to provide some context for what I'm looking for. A lot of times I can remove answers before I even read the question. Sometimes I can determine the question before I even read it. So this one, A, B, C, and D. A says she denies chest pain. Okay. So again, I don't know what the question is, but she denies chest pain. I'm assuming it's some sort of a respiratory or cardiac event, or maybe trauma where I'm worried about chest trauma. Okay. So she denies chest pain. Her oxygen saturation is normal. All right. So this has got something to do with perfusion, and I'm thinking maybe a respiratory emergency. C is elderly patients often have atypical presentations of cardiac ischemia. So now I'm thinking maybe criteria for cardiac emergencies for a geriatric patient. And then D, bradycardia is expected in older adults. That's garbage. We don't expect bradycardia. Is it fairly common? Yes, but do we see it just automatically assume it's like, well, they're old? That one's out already, because that seemed like a bunch of hot garbage to me. So I've got these three questions now. She denies chest pain, which is going to be the symptoms the patient is experiencing. Her oxygen saturation is normal. I'm looking at the signs, right? This is part of our vital signs that we're looking at. And then elderly patients often have atypical presentations of ischemia. So maybe an elderly patient with cardiac issues. So now let's look at the question. You respond to a 72-year-old female with weakness. She is pale and diaphoretic. Vital signs, blood pressure 88 over 54, heart rate 46, respiratory rate 18, and SpO2 96%. Skin cool and clammy. She complains only of nausea and weakness and denies chest pain. What should most strongly influence your treatment decision? So we kind of narrowed it down to three. All right. One was her oxygen saturation is normal. That's not really going to affect my treatment decision. Pulse ox is kind of, it's delayed. It's not really diagnostic. It's kind of just like a reference tool, but I'm really looking at the skin. So that doesn't do much for me. She denies chest pain. That doesn't mean much because she's an elderly patient. So that leaves us with elderly patients often have atypical presentations of cardiac ischemia. The answer is going to be C. And I already kind of knew the question itself was going to have to do with cardiac pain in geriatrics if that was the answer. So that was the answer. We got to rule some things out. Let's look at another one. I really wish I could bring this up for y'all. The answers: tachycardia, So fast heart rate. Okay, this has got something to do with a fast heart rate. Seatbelt sign. All right, so seatbelt sign, if this question has something to do with a motor vehicle accident and chest trauma, that's probably going to be the answer. Chest pain, that could be medical, that could be trauma. Normal blood pressure is going to tell me they're a stable-ish patient. So normal blood pressure, stable-ish patient, chest pain, medical or trauma, seatbelt sign, car accident, tachycardia, could be a variety of things for the patient to be excited. So the question now, the patient was involved in a high-speed motor vehicle collision. Already, I'm kind of going back down to the answers now and thinking, okay, I'm seeing some correlation. He is alert and complains of chest pain. Assessment reveals equal breath sounds, trachea midline, and seatbelt sign across the chest. Blood pressure is 118 over 78, heart rate is 118. So which finding is most concerning? Well, they were in a high-speed motor vehicle collision. Their vitals are fairly stable. You'd expect the heart rate to be up, but bruising is abnormal. And what's underneath where that seatbelt goes? A bunch of important things, right? So the fact that I'm seeing signs, I'm seeing evidence that is supporting the chest pain is going to elevate that to being more concerning. So just reading the answers again, that helped us see what we might be talking about in the question. Let's see if we can do one more. All right, so our answers. Check a blood glucose. So I'm thinking some sort of a diabetic or altered mentation question. So if the question's got to do with diabetes or altered mentation, this is a player. Insert an airway adjunct. Okay, well, that's somebody without a patent airway. Snoring respiration. So I do an airway adjunct if I see snoring. So if the question is snoring in it, I'm going to be leaning that direction. Begin ventilations if indicated after assessing airway and breathing. Okay, so begin ventilations. Remember when we were doing our studying and you're going through school, there was the 3 phases of basically breathing. You've got ventilation, oxygenation, and then respiration. Ventilation is like when you're in the bathroom doing work and you turn the fan on because you want to move air. It's just a mechanical movement of air. I can ventilate a steak. It doesn't mean it's going to breathe. It just means I can throw air at it. So that's ventilation. Oxygenation is actually when the blood binds to, or the oxygen binds to the cells. So the oxygen is actually getting into the body. It doesn't mean that breathing is occurring. If I have no exhale, I could still bag somebody, or I could still put a nasal cannula on them and they can be getting oxygen in their body that maybe their blood is accepting. But unless there's waste product and CO2, respiration isn't occurring. So ventilation is the mechanical movement of air. Oxygenation is oxygen getting in the bloodstream, and respiration is the exchange of goods. Oxygen in, waste product or CO2 out. So begin ventilations if indicated after assessing airway and breathing. Begin ventilations means there's some sort of a ventilation problem. This patient is not moving air. It's not that they're not doing well with the air that they have, it's the fact that they can't move it. So if I see slow, shallow respirations, I'm thinking ventilatory problem. It's going to require a ventilatory solution. So that question is going to be a player. And then administer oral glucose. All right, well, when would I administer oral glucose? This goes back to an altered mental status or a diabetic problem. But who gets oral glucose? Patients that can control their airway. So in looking at this question, administer oral glucose, diabetic emergency that can control their airway, begin ventilations if indicated. They have a problem moving air, a ventilatory problem. Insert an airway adjunct, snoring, keyword snoring, or check blood glucose. The patient is stable, and I'm getting some diagnostics for them, right? Because I have time to deal with this. So now let's look at the questions. A diabetic patient becomes unconscious while you're obtaining vital signs. You should first. All right, so a diabetic patient becomes unconscious while you're obtaining vital signs. Check a blood glucose. Well, that's diagnostic, but if we go back to our medical trauma assessment, vital signs are kind of further down below. This patient just went unconscious, which brings us back up to an apparent life threat. So with an apparent life threat, I might need to do something about it. So check blood glucose. I'm kind of throwing that one out because they're unconscious. I got to make sure that they're stable. Insert an airway adjunct. I didn't hear anything about snoring respiration, so I'm not going to rule it out, but there's nothing that says there's an airway problem here. C is begin ventilations if indicated after assessing airway and breathing. Well, our patient just went unconscious. We are right back up at apparent life threat, so we've got to hit that ABC. All right, so now I'm thinking I should probably assess this and maybe move some air for them because I don't know if they're moving air. Administer oral glucose, we know that one's out because they don't have a patent airway because they're unconscious. So we're pretty much narrowed it down now to insert an airway adjunct or begin ventilations. And this is where you're going to have to make a judgment call. If when we're taking the exam, we see the questions that we know and we're able to answer those questions, awesome. And then the ones that we're not sure on, we can narrow it down to 50-50. I like those odds. So if we do the questions we know and then narrow it down to 50-50, there's a very good chance you're going to pass this exam. So between these two, I'm going to be looking at begin ventilations. I don't see anything about snoring respirations. I don't see anything about the airway other than they're unconscious. If it's a diabetic patient, I kind of know they have irregular respirations a lot. So I'm going to get ventilations if necessary, but I definitely want to assess the airway and breathing, because if I assess the airway, then I know I need to do an airway adjunct. But I need to assess the airway before I step into it. So the answer to this one is begin ventilations if indicated after assessing airway and breathing. All right, so that's some examples of questions and reading answers. Test taking strategy is very, very important because there's a lot of information that we go through in the textbook, and there's a lot of information that we get when we go to take the exam. And learning to differentiate what's important and what's not is important can really help us dial in when we're doing the exam. So practicing reading those answers, super helpful, because you can see what is reasonable, what is unreasonable, and so you get rid of some of those right then and there. And then you can also get an idea of what type of emergency we're looking at. Is this a trauma answer? Well, then if it's a trauma question, that's a player. Is it a medical question and all three of the other answers are trauma? Well, if it's a medical question, not trauma, I know that's the answer. Is it got to do with airway sounds, right? Well, okay, so we've got stridor, we've got rhonchi and rales. I don't know what the question is yet. I haven't read it, but I do know stridor is an upper airway emergency. I know rhonchi and rales is a lower airway emergency. So now when I read the question, if it's talking about upper airway stuff, I kind of can already get rid of the rhonchi and rales. And now I'm just down to two options or stridor. So that test taking strategy isn't for everyone, but it is a tool you should put in your toolbox, because when you come across a difficult question and you're starting to get spun and you're thinking, I don't know what they're asking, let's go to see what the options are. Let's look at the answers and see if we can filter it down. I was doing a question with a student earlier today, and he was talking about cardiology and the intrinsic pacemaker. Well, before we got to the pacemaker, before we got to the question, two of the answers said node. One was Purkinje fibers and one was, I can't remember the bundles, or I think it's something to do with atrioventricular notch or something like that. Well, when I was looking at the answers, two of them had to do with nodes. So I'm thinking, okay, if the question's got to do with originating an impulse, it's going to be one of those two. If it's got to do with just the electrical energy transferring through part of the heart, well, then Purkinje fibers is going to be a player, because Purkinje fibers, the electricity travels through it, right? It's not a primary pacemaker. All cardiac cells can induce a pulse, but it's not a primary pacemaker, right? Like the nodes are. And then the last one was the atrioventricular notch. Well, okay, if it's something got to do with the middle of the heart, then that one's a player. And so then we went up to read the question. It said, what is the primary or the intrinsic pacemaker of the heart? Well, now we've got it narrowed down to two, because two of them are nodes. So maybe I don't know which is which, but at least I've narrowed down to 50-50. And in this particular question, it said sinoatrial node or the AV node, the atrioventricular node. All right, well, I'm not sure what's what, but I do know that the atria is above and the ventricles below. So atrioventricular would be where those two things meet. Okay, so it's going to be more in the middle. The sinoatrial, I know the sinus is up top. I know the atrium is up top. I don't know what that is, but I do know it's up high. Well, now you got a 50-50 shot. where does the pulse originate from? Where does that impulse originate from? And the answer is the top of the heart. So even though I didn't necessarily know the answer, or a student didn't necessarily know the answer, we could reduce it down to who the true players are, right? A node, impulse. So that is another example of why this test taking strategy is so important. So to recap some of the stuff that we talked about today, find a place to study where you're not quite as stressed. Just practice being calm. Have a note sheet next to you. As you come across a difficult topic or something you didn't understand or you want to remember, write it down. Remember, you're not actually taking the test. You're not cheating while you're studying. If you're at school and you're taking an exam, okay, yeah, don't use your notes unless your teacher says so. But you are literally in your own study time. As you read something, as you think about something, and then as you write it down and then look it up, you're going to remember it completely different because you're approaching it from 3 or 4 different angles. So take your notes. And then also you can learn what notes are important to you so you can remember to word vomit those out on exam day on your cheat sheet. The concepts and norms. Remember correlation. If you see a question that says the patient has urinated on themselves, they bit their lip, and they're improving over time, that's consistent with seizure. I don't care what else is going on in the question. If they're improving over time and they've urinated on themselves, that's a seizure because that's just a textbook EMT answer. We talked about pneumonia earlier. So they've got a fever and green sputum. Okay, that's pneumonia. There can be 1,000 different respiratory illnesses, but those two things are consistent with pneumonia. Emphysema, they've got a history of COPD and barrel chest. Well, when I see barrel chest, the answer is emphysema. I don't need to know much else because they simply go together. It's like peanut butter and jelly. When you're studying, don't so much look for what's the same in these types of emergencies, but look for what's different because that's going to give you some correlation and then you're going to see it on the exam. So knowing the concepts and the norms and seeing those correlations. And then, of course, your assessments. Know your assessments from top to bottom. Next time we do a video, we'll talk about some ways you can remember your medical trauma assessment, but at least know that first half. If you know the first half, you know 50% of both assessments. They're the same. If you look at the sheet, it is the same step by step. There's one little section where the blocks are different, but it's entirely the same information. So keep that in mind for the assessment. It's going to go a long way when you're taking an exam. And then lastly, when you're taking those practice exams, practice just reading the answers and trying to see what type of question it might be. You might be surprised at how good you get at guessing what type of question it is. You might rule out 2 or maybe even 3 answers before you even read the question. And then just read the question and look for those key words. Is it green sputum and fever? Okay, well, right away I'm thinking pneumonia, right? Do I see the word wheezing? Well, if I see wheezing, I'm automatically thinking albuterol. Okay, maybe it's an allergic reaction question, but you know what? Albuterol is something we might do for an allergic reaction. It just depends on what the rest of the question says. But once I see these key words, it's got me thinking about something that I can look for. So that's it for today. Sorry, this one was a little clunky. I'm new at this, but I'm pretty good at these test taking things. So hopefully you come back, and don't forget to check out the channel for more information. I'll be on here more, and send in your questions because I know specifically what you're looking for. I know specifically how to answer it. So thanks for your time today, and I will see you soon.